Good afternoon. Welcome, everyone. We're going to give a few minutes and let people get logged in and get our computers set up.
Oh. Okay. I didn't have the share screen.
All right, we'll get started. Welcome. Good afternoon. Thank you for joining us today on this beautiful Friday in the middle of July. I hope that everyone is having a beautiful day. So welcome to the American Parkinson's Disease Association's fall webinar series, Parkinson's Educational Webinars. And my name is Amanda Brill. I am a social worker, and I am also the American Parkinson's Disease Information and Referral Coordinator, and I'm hosting this series. This is the mission statement. The American Parkinson's Disease Association, or APDA, is the largest grassroots network dedicated to fighting Parkinson's disease. We work tirelessly to assist the more than 1 million Americans with Parkinson's disease live life to the fullest. APDA distinguishes itself as the national organization working one-on-one with the Parkinson's community to make each day better. You can find out more about all the resources the APDA has to offer by visiting us on our website or by calling 860-734-6393. The American Parkinson's Disease chapter in Connecticut is fortunate to have a wonderful board that does a lot of work to support everyone in the state. We have the Information and Referral Center associated with Hartford Healthcare, and I help to set up these webinars for education and for support. Hartford Healthcare was very fortunate to have been chosen to host only one of 23 APDA Information and Referral Centers in the United States. I'm always available and at your assistance to help you with anything that you may need regarding education, resources, supports. I wanted to give a shout out that we are looking for support group facilitators. If you're interested in volunteering, if you're interested in getting more involved in the community, we are looking for support group facilitators in Ellington, Vernon, Westport, and Willimantic. And please reach out to me if this is something that you would be interested in, or if you live near one of these areas. that you would like to start up a group, if you'd like to continue a group that's already been established, please reach out to me. And now, just for the ground rules, you'll notice that this is Zoom platform. You have all been muted to minimize unintentional distractions to the speaker from background noise. We do want to hear from you, so please feel free to type any questions that you have. At the bottom of your Zoom screen, there should be a chat option and a Q&A option. You can put questions into either of those. You have to hover your mouse over towards the bottom and they should display. We will answer questions at the end, but you can type them in to the Q&A or chat at any time throughout the webinar. And don't forget to tune into our other educational webinars we have planned. We have another one planned in September, and you will get some more information on the website about that and in emails. And I would like to introduce now our speaker for today. Dr. Elena Bortan is a movement disorder specialist with the Iyer Neuroscience Institute, Chase Family Movement Disorder Center. And Dr. Bortan came to Hartford Healthcare from Middlesex Hospital, where she worked for almost a decade. She earned her medical degree from Carol Davila University of Medicine and Pharmacy in Romania. She completed a residency in neurology at Tufts New England Medical Center and a fellowship in movement disorders at the Leahy Clinic. She is fluent in English and Romanian, and she is a board certified neurologist and member of the American Academy of Neurology and Movement Disorder Society. She sees patients in our Mystic office, and we are so glad to have her here today to speak. And I'm going to stop sharing my screen and she will begin to share her presentation.
Thank you so much, Amanda. Just a moment, please. Let me see if I can deal with those technical challenges. Okay, and just a moment. Sorry about this. Are you able to see my screen, Amanda?
Yes. Yeah.
Okay. Is this better?
Yep. That's great.
Okay. Thank you so much. Thank you, everyone, for being here with us. Thank you for inviting me, Amanda, here today to discuss about topics which are very important in our patients with Parkinson's disease. More than happy to answer to questions after my presentation. If we don't have time to answer during the presentation or immediately after the presentation, I'll be more than happy to take questions and send by email to patients who are asking questions. Then the topic for today is talking about what we are not seeing in patients with Parkinson's disease. And those are called by us non-motor symptoms. Then, just a moment, please. Okay. Then Parkinson's disease has traditionally been considered a motor system disorder. Motor means something which is moving. Like tremor at rest, like bradykinesia or slowness of movements, rigidity or stiffness of our limbs, of our shoulders, let's say, or postural changes. Those are described in the category named motor symptoms of Parkinson's disease. A common metaphor for Parkinson's disease is an iceberg, as can be seen here in this screen. You can see very well. Sticking out of the water are the visible motor symptoms. I was just discussing about them: tremor, muscle rigidity, slowness, postural changes. And patients and the family members and the friends are very familiar with those symptoms, but under the water is a big portion of the iceberg, which is much larger and is representing invisible symptoms, many non-physical, that occur in Parkinson's disease. Then this is a very perhaps complicated brain view. It's a sagittal view. What does it mean? Is a profile of our brain. This is a portion of the brain which is called brainstem, and the rest of the brain is our big brain with a cortical area with some structure of the brain. We're not going to discuss about structures in the brain, but why it's very important, this section of the brain, is to understand that changes which are noticed in the brain of Parkinson's disease patients are noticed before the motor symptoms start to be noticeable by the patient or by the family or friends of the patient. Then 2000, the year of 2000, it was probably the most important advances in Parkinson's disease. The Bragg hypothesis links neuronal pathology with clinical pathology in Parkinson's disease. What Bragg proposed at that time was that the fact Parkinson's disease is not a motor disorder when it started. It is started in the lower side of the brainstem, and it is started in an area of the brain which is called the olfactory area, which is responsible of our smell. Then in the first stages of the disease, when we are not having more motor symptoms, we are losing the smell, we start to have gastrointestinal problems such as constipation. Later on, the changes in the structure in the cells it progress towards the mid side of the brainstem right here, where is the sleep center, and patients may start to have some sleep disturbances such as restless leg syndrome or REM sleep behavior disorder. Perhaps some of you heard already about those symptoms. And in the stage 3, like 15, 20 years after abnormalities in the brainstem are noticed, patients started to have motor symptoms when these abnormalities are started to affect upper part of the brainstem in a structure which is called substantia nigra. Then again, this is a Bragg hypothesis, which is showing that loss of smell, constipation, bladder disorder, sleep disorder, depression are noticed in patients who may develop motor symptoms of Parkinson's disease later in life, like 15, 20 years later from the non-motor symptoms start. Then, as I said, the early non-motor features which are noticed in patients who are developing later on motor symptoms of Parkinson's disease are impaired olfaction, which means loss of smell, constipation, erectile dysfunction, REM sleep behavior disorder, depression, anxiety, fatigue. And those of them, based on Bragg hypothesis, make sense to relate to the fact that all of these changes are happening in the parts of the brain which are not responsible of motor symptoms. Now, here I try to make a classification of those non-motor symptoms in Parkinson's disease, which are under the title of cognitive psychiatric, including anxiety, depression, fatigue, slow thinking, hallucination, sleep dysfunction, dementia. Autonomic dysfunction, we're going to discuss later about those. Sweats, runny nose, I didn't place it here, dyspnea, orthostatic hypotension, sexual dysfunction, urinary dysfunction, constipation, as well as sensory problems, a tingling, akathisia, a sensation of restlessness, olfactory deficit, meaning loss of smell, loss of taste as well for some patients, and diffuse pain. Now, we're going to speak a little bit about each symptom, and I'm going to start to discuss about sensory deficiency in Parkinson's disease patients. And one of the symptoms which is very frequently noticed is loss of smell. Smell impairment can be noticed in 70 to 90% of patients, may develop, as we said, very early in from on the onset of the disease before the motor features. Impairment of smell is very interesting, can be selective. I heard many patients saying that they cannot smell coconut or banana, but they can smell, for example, strawberries or chocolate. Unfortunately, there is not any specific treatment for this type of loss of smell. Visual impairment. Visual impairment for many, I mean, I don't think that too many patients or too many physicians are paying attention for visual disturbances in patients with Parkinson's disease, but there are many patients with Parkinson's disease. They said that they have blurry vision or tired eyes or intermittent double vision, which can be seen in about 15% of patients. Some of them have reading difficulties seeing in a dim lightening condition. This is very important. And why is important? It is important during the nighttime when you are driving a car, when you go to a restaurant, reading the menu, you cannot see very well. But what is the most frustrating for all of these patients? They are going for an eye specialist, they have an exam, and they are told you don't have anything, your eyes are fine, especially after doing a visual acuity test. But there are some other reasons for which patients with Parkinson's disease, they are not seeing very well. For example, convergence insufficiency. Convergence insufficiency is when you want to look to something very close to the eyes, and this problem is generating your eyes to come almost crossed, almost very close to the base of the nose. But patients with Parkinson's disease do not have difficulties, difficulties in doing that. Then impaired color perception. Some patients may not be able to distinguish some colors of the objects. Also, abnormalities of blinking, very frequently seen in patients who had Parkinson's disease, especially when they have this loss of expressivity of the face. We are describing like facial masking. We are describing like loss of blinking. Patients are blinking less frequently. This is generating dry eyes, generating blurry vision, and difficulties in reading, obviously. Some patients, though, may have difficulties in opening their eyes. It's called eyelid apraxia. And this is rare seeing in Parkinson's disease. Sometimes it's seen in patients who had Parkinsonism. And the best treatment for this problem is botulinum toxin injections. I'm going to discuss later about this. Some patients may have what is called reduced contrast sensitivity. What is this reduced contrast sensitivity? It's consistent with ability to distinguish between an object and the background behind it. Then this is normal. Normally, we have to be able to distinguish between an object and the background behind it. Even if the object which is behind it is a little bit has a fade color, but the same color as the object which we are looking to. This type of contrast sensitivity is different from visual acuity. This is the grill which is used in ophthalmology office to distinguish this contrast sensitivity. And perhaps it's more important in patients who have Parkinson's disease comparing with testing visual acuity. Why? Some articles showed that people who had reduced contrast sensitivity in Parkinson's disease, this is due to some loss of dopaminergic neurons in the retina. And then this is very important. Why? Because a patient is not able to drive, for example, in rain, in low light, in glare, in fog, and can affect specifically driving. Then different treatment which we are, using for visual dysfunction. First of all, we are sending our patients to an eye exam. Sometimes we are sending our patients to have a neuro-ophthalmology evaluation, more detailed examination, which is very important, especially patients who had double vision. They can benefit for prism in their glasses. Patients who had dry eyes and it's happening frequently. They can benefit from artificial tears. We discussed about this impaired contrast sensitivity. Some studies show that people who are playing video games, they have a better contrast sensitivity than other people. But we do not know specifically how is this working in Parkinson's disease patients. And I would definitely not recommend you guys, all of you, to start using any kind of video games more than 1 hour a day, because that is not going to be good for you. In terms of blepharospasm or apraxia of the eyelids, I explained to you apraxia of the eyelids is difficulties in opening the eyes. Botulinum toxin is very well known to help those patients, and it's not it's an easy procedure for me as a physician. It's caring for patients who is expecting to receive a needle very close to the eye, but is working in some of the patients, and is very welcoming in our movement disorder ward. Why? Because cannot produce systemic side effects such as drowsiness or impaired cognition, which patient could notice if we are using strong medication to help blepharospasm. Now, another problem in Parkinson's disease, and perhaps is not very well recognized and not very well explored by many physicians, is pain. Pain is very common in patients with Parkinson's disease. Up to 50% of patients may have pain. The prevalence in some of the research studies showed the pain estimated to 40 to 85%. From clinical standpoint, the pain can have a variety of aspects. You can spend the entire visit during the office visit just talking about pain. Many patients may have more than one type of pain. The pain is different from one patient to another. We have to take that in consideration. In some patients, maybe the number one predominant symptom which you are dealing with. For some patients, maybe the first symptom of Parkinson's disease. For example, some patients may have shoulder pain, and this shoulder pain is because of stiffness and rigidity, not necessarily having a musculoskeletal pain due to joint problems or ligament problems. I'm sorry. Then there are different types of pain in Parkinson's disease patients. Those are musculoskeletal pain, neuropathic or radicular pain, dystonic pain, central pain, and akathisia. I will speak just a little bit about each type of pain. Musculoskeletal pain is the number one cause of pain in patients with Parkinson's disease, and it's caused by stiffness, rigidity. Because what is happening, you start to use different muscles which your body has not used before to improve alteration in posture and movement. When you adjust, you develop different musculoskeletal stressors. As a result, patients can have cramping, aching, joint pain, may or may not be related to motor fluctuations. Motor fluctuations meaning decreasing in the level of pain or stiffness, which generate pain due to taking dopamine medication. Neuropathic type of pain or radicular pain is a pain which means which is due to a pinched nerve, let's say, is described in a specific area of the lower extremities or upper extremities. Dystonic type of pain is very important in patients with Parkinson's disease. What is dystonia? Dystonia is a sustained muscle contraction causing twisting and repetitive movements and or abnormal posture of different extremities. Many patients are describing curling of their toes, especially during the nighttime, or twisting of the ankle of the foot, which is an incoordinating twisting and sometimes can be very painful because of wearing off dopaminergic medication, or sometimes could be because of too much medication which the patient is taking for Parkinson's disease. primary central pain is a very, very sophisticated, let's say, pain. Is a pain which is characterized by not a radicular pain, not musculoskeletal pain. Is very challenging for physician to treat. Some patients may describe a severe burning sensation of their mouth, or a severe burning sensation or their genital area, which cannot be related with anything else, with other type of pain, and is due to is considered to be generated from the same area where abnormal cells in Parkinson disease are noticed, and I'm naming here basal ganglia. Akathisia is a type of restlessness. It's not restless leg syndrome. It's a subjective feeling of inner restlessness. It is generalized feeling of intolerance of staying still. The patient cannot sit down for more than 2 or 3 seconds on the chair. They are standing up, they are moving around, they cannot find their place, and it's very painful for family, and it's not very painful, but it's very annoying for patients, and it's very, very hard to treat this. There are different treatments of pain in Parkinson disease, and always we have to ask the help of general practitioners. We have to ask the help of a general neurologist. We also send patients to pain management sometime when the musculoskeletal pain is unbearable. We have different types of medication we can provide to the patient. It's very important to find out if the pain is related with off period meaning when dopaminergic medication is wearing off. That means that we have to optimize dopaminergic medication for Parkinson disease. We have to be sure that this pain or dystonia is not related with on time or too much dopaminergic medication. Some of the medication which we are using are having a lot of side effects, like for example, baclofen or other muscle relaxant can produce a lot of drowsiness, can produce a lot of decreasing concentration, which are generating subsequently risk of falling. For dystonia, if it's a specific dystonia in one of the limb, we prefer botulinum toxin injections. It's an injection, it's painful when we introduce the needle, but with so much improvement of the dystonia in some patients, avoiding to give medication which can produce a lot of drowsiness. Next, just a little bit discussing about dermatologic findings in patients with Parkinson disease. Seborrheic dermatitis is common in 20 to 60% of patients. Melanoma is a malignant tumor of the skin, occurs with a higher frequency in Parkinson disease than in general population. It's been described near 2 times higher in patients with Parkinson disease. Melanoma risk is elevated even if before starting exposure to levodopa therapy. You heard some patients, we are discussing with patients, you have to go to see a dermatologist at least once a year to be sure that you don't have a new abnormality of the skin, and be able to see if it's something abnormal earlier rather than later. Autonomic dysfunction. Complicated autonomic dysfunction is something which you can is seen frequently in patients with Parkinson disease. What is autonomic nervous system? It's the part of the nervous system that controls unconscious bodily function. You cannot control your blood pressure. I cannot control my heart rate. I cannot control sweats. Partially we can control bowels and bladder, but there are so many other things, our processes in our body, which we cannot control. And this is the reason for which I want to discuss today, because some of them are very important to discuss with your physician when you go for follow-up visit, or to be aware that they can exist. Drooling. We're going to start with some gastrointestinal autonomic dysfunction. And I'm going to start with drooling, which can be seen in 50 to 70% of patients. Drooling is not because of too much saliva, it's because of decreased swallowing frequency in patients with Parkinson's disease, decreased swallowing efficiency in some patients. For some patients, could be because of tendency of keeping the mouth open, because of severe stiffness of the face. Some patients may walk with stooped posture and mouth open, and they can have drooling as well. Some patients may have nocturnal drooling, and in general, we notice, and there are researches which show that in patients with Parkinson's disease, is not excessive saliva. In fact, saliva production is usually decreased. There are different treatments, depend on the level of drooling, chewing gums. We sometimes advise the patient to do it, especially if they attend some of social meetings. If it's, of course, if the patients will be eager to do that. If the drooling is very impaired, or the drooling is impairing patient social activities, and there are very and it's very exaggerated, we ask sometimes to place atropine eye drops under the tongue. Those are quite safe, but some patients may have lowering of the blood pressure, or even if confusion. If the drooling is very, very severe, we are recommending botulinum toxin to be injected in a salivary gland. It's very easy procedure for us. Again, it's not easy for the patient because he's scared about, majority of my patients are scared about botulinum toxin side effects, but they are doing very well. Sometimes can produce dryness of the mouth, and in that situation, we have to treat the dryness. But always when we start to do botulinum toxin, at least myself, I'm starting with a lower dose, and I'm increasing the dose gradually, depending on the response. Other gastrointestinal problems are impaired gastric emptying, causing nausea, vomiting, decreased appetite, abdominal bloating, and subsequently sometimes abdominal pain. We always send the patients to our gastroenterologist colleagues to help us. One of the treatment is prokinetic agent. Please do not use something which is called metoclopramide or Reglan. This can worsen Parkinsonian symptoms. Parkinsonian symptoms meaning motor Parkinsonian symptoms. Some patients may have small intestinal bacterial overgrowth, and this is very important because can decrease the medication absorption. Constipation can be seen in up to 80% of patients with Parkinson's disease. This is the reason for which always when you are coming in our office, we are asked about constipation. We ask you to avoid dehydration. This is one of the main treatment for constipation. Water, 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 especially if there are no fluid restrictions. We ask the patient to use high fiber foods. We ask the patients to use different types of medications, softeners, stimulants. There are different kinds of medications, and sometimes the constipation is severe. If a patient had a bowel movement every 7 days, we ask the help of primary care physician, ask the help of gastroenterologist as well. Urinary dysfunction is very well known to be a problem in patients with Parkinson's disease, especially overactive bladder. It's been noticed in 53 to 80% of patients with Parkinson's disease, and clinically is described like frequent urination, urinary urgencies, 9-time urination, urge type incontinence. And this is because of the muscles of the bladder are contracting before the bladder is full with urine. This is very important. It's important to treat, and it's important to know if the patient is bothered about waking up every 2 hours, going to the bathroom, because that means not good sleep. That means next morning the patient can have drowsiness, can be sleepy all the time, because during the nighttime he's just going to the bathroom. There are different medications as well. I'm not going to enter and describe every single medication. I just want you to know that there are resources and there are possibilities to treat this. And many times we are asking our urologist colleagues to help us in treating those. Some patients, not especially men's, for example, they may have problems with prostate. They can have an enlarged prostate. They have to see a primary care physician and urologist to see if they can help with the symptoms. Sexual dysfunction is seen frequently in patients with Parkinson's disease, earlier in the disease, before motor symptoms, and consistent with erectile dysfunction, decreased libido, decreased orgasm. In women, reduced vaginal sensitivity, decreased desire in up to 80% of patients. There are different medications which can be used. We always will ask primary care physician or urologist help or gynecologist, because the patients may have underlying medical conditions which can necessitate to avoid using some of the medications. Orthostatic hypotension is a very important, let's say, non-motor symptom. Orthostatic hypotension means lowering the blood pressure when you are sitting from lying down or standing after sitting. Is like a drop of more 20 points in the systolic blood pressure, can occur in 50 to 60% of patients with Parkinson's disease, produce symptoms in 1/3 of patients with Parkinson's disease. Not all of the symptoms who had orthostatic or lowering in the blood pressure can have symptoms. And clinically, symptoms are very important for you to know. Those are dizziness, describing dizziness, like lightheadedness after standing up, fainting, disturbances in vision for some patients after standing up, impaired thinking or staring face after standing or walking for 3 minutes, headache for some patients, which is described in a coat hanger distribution, meaning the back of the head lowering or radiating to the shoulders area. Treatment of orthostatic hypotension is very important. We have to identify if there are any other medications in patient treatment which can lower the blood pressure. Dehydration, important as in constipation. Good hydration means 48 to 64 ounces of water a day. Sometimes we ask the patient to add salt in medication. We have to be very careful, especially in patients who had high blood pressure. Some physical maneuvers like crossing the legs or opening, closing hands before standing up for patients who are dizzy and had drop in blood pressure. Eating small meals and more frequently abdominal binders or pressure stocking for some patients. As medications, we have different types of medications which we are using for patients who had orthostatic hypotension, cortisone, midodrine, droxidopa, mestinone sometime. Temperature dysregulation is very important. Hyperhidrosis or excessive sweating is important, seen in 50% of patients. Is described like a sudden drenching sweats, which can be seen in patients who are off medications, is associated with anxiety, and can be noticed in patients who are off medications or on medications when they have too much medications. Cognitive impairment is very important. We're going to start with fatigue. can occur prior to motor symptoms, sometimes can be the most disabling symptom in patients who had Parkinson's disease. The patients are saying, doctor, I don't care about the tremor. I don't care about my walking. I can do it. But this problem, I can't stand up and do things which I was able to do it before. Is different from depression, from excessive daytime sleepiness, for apathy. It's impacting quality of life of the patient. It's not easy to treat. We try to emphasize the fact that they have to have a program, an exercise program. Sometimes we are using some stimulants, but with not good results in patients with Parkinson's disease. Caffeine, sometimes Parkinson's disease medications may help, but for some patients, our strategic medications cannot, or they are not sufficient to help the symptoms. Apathy is a loss of motivational drive. It's characterized by diminished speech, diminished motor activity, diminished emotional expression. It's this sensation of care partner, of patient being indifferent. He's indifferent of everything. Maybe he's, sometimes touched the fact that a grandson is coming to visit, but otherwise, it's very, very painful for the care partner to see those patients who are emotionless. Treatment is very sophisticated. We don't have a specific medication for that, but we are trying to find strategic plans with the help of our social workers, who are great to help them and to guide the care partner to have the patient involved in different activities. Depression and anxiety. Depression is one of the most common psychiatric disturbance noticed in patients with Parkinson's disease. Depression is associated with increased motor disability, decreased quality of life. There are plenty of medications which can use. Usually we try to find out if there is any other, or there are any other medical problems which can explain depression. Check thyroid hormone, ask the patient to have a good sleep, ask the patient to be involved in exercises every week, optimize Parkinson's disease treatment. Sometimes they benefit from cognitive behavioral therapy, sometimes can benefit from medications. And those are different medications which we can use in different patients. My message for today is every patient is different. Every patient has different underlying medical problems. Do not compare yourself with your neighbor, with your friend who has Parkinson's disease, because you have different other medical problems, and your Parkinson and your symptoms are different. Cognitive dysfunction is a broad notice in patients with Parkinson's disease, usually occur years after motor symptoms are noticed. Cognition affect, especially short-term memory. They have difficulties with multitasking, trouble with planning. I'm sorry about the spelling, and managing tasks. Some patients who had Parkinson's disease, not necessarily with dementia, can develop psychosis, noticed in 20 to 40% of drug-treated patients with Parkinson's disease. Some patients may have severe depression with hallucination or psychosis. Some patients may have dementia with psychosis related with Parkinson's disease. Hallucinations usually can be visual hallucinations, when you see people, when you see a baby close to you, more than auditory or tactile hallucinations. Delusion is a impression that something wrong happens. You don't see, it's not a hallucinations, but usually it's an unusual paranoid idea. Usually it's very painful for the patient and for the spouse who is caring for 24 hours to see that the husband or the wife start to say that you are seeing someone, you are having a boyfriend. This spousal infidelity is very painful for a caregiver. They also can imagine that people are coming, stealing monies, intruders living in the house, or nurses planning harmful plots. There are different tips for cognitive changes in Parkinson's disease. We can speak next time an entire topic to be just cognitive changes in Parkinson's disease. Perhaps we need 5 hours and we can talk about it. But what I want, my message is, talk to your doctor, talk to your movement disorder specialist, talk to primary care physician. There are some strategies, and we can help with understanding of cognition decline, if indeed there is one. Psychosis sometimes is very, very important, and is very important because many patients arrive to long care facility because of an inability to treat psychosis. But we're gonna, this is something to discuss in the next presentation. Compulsive behavior can be seen sometime, especially if we are using dopamine receptor agonists such as Mirapex, Requip, Nupro, and those are gambling, hypersexuality, hobbies, collecting, binge eating. This is the reason for which many times when you come to the visit, we are asking about it. Sleep dysfunction, very broad. Many patients may have insomnia, fatigue. We discuss about fatigue, excessive daytime sleepiness, REM sleep behavior disorder, restless leg syndrome. Insomnia can happen in many patients, usually not trouble getting to sleep, but trouble to stay asleep. Commonly, patients are getting early to bed, but they have described an early wake up. Total sleep time can be normal, but patients can be tired. We have to have some strategies, avoid late naps, okay, short naps during the day, avoid alcohol, especially in the evening, avoid caffeine after 4 p.m., exercises, daylight exposure. And if you are unable to fall asleep, don't stay in bed entire night. After 30 minutes, it's better to go out, to go stay in the chair, read a book. Do not associate the bed with, watching TV or reading a book, because the bed should be associated just with sleep and intimacy. There are different medications and strategies which we can use for it. We can discuss during your visit appointments. REM sleep behavior disorder is very important to know. What means patients start to have abnormal movements in a period of time, in a period of sleep where our body should be paralyzed, with no movements when we are dreaming. Patients who had REM sleep behavior disorder, they can start to kick with arms, with legs during the nighttime. They can kick the spouse, not because they want to, they cannot control this. And this is something which is being described up to 80–90% of patients prior to let me say in another way, 80 or 90% of patients with REM sleep behavior disorder may develop symptoms, motor symptoms of Parkinson's disease after 15–20 years of developing REM sleep behavior disorder. There are different treatments which we are using in REM sleep behavior disorder. Usually we start with very safety precautions. Lower the bed, place a pad on the floor, have the spouse move to another bed. But melatonin is the first drug which we ask the patient to take. Sometimes clonazepam, this is a benzodiazepine. We have to be very careful with benzodiazepine because those can produce drowsiness, decreasing concentration during the nighttime, and subsequently can produce increase in falls. Restless leg syndrome is very broad notice in patients with Parkinson's disease. We have different types of strategies. There are medications which we can use, and in general, medications which we are using for improvement of motor symptoms, we are using in treatment of restless leg syndrome. Now, I think that I spoke too much, and I think that my time is almost gone. As a conclusion, what I want you to know after this, speeding talk about non-motor symptoms, I want you to, to leave from this presentation with a couple of ideas. Non-motor symptoms may precede the development of motor features, may develop early in Parkinson's disease before the motor symptoms occur, impact quality of life, sometimes more than motor features, like I said, fatigue, psychosis, dementia in some patients, may become dominant feature in advanced Parkinson's disease. Major causes of hospitalization and placement in long-term facility in Parkinson's disease are due to non-motor features. I want you to know that there are effective treatments often offered for a treatment of non-motor features. But is it very important to discuss about symptoms or other symptoms than tremor, rigidity, stiffness, gait problems during the visit? Because sometimes maybe the physician is not asking, maybe you don't know about it. Then the reason for this presentation is not to scare you. The reason of this presentation was to be aware of possibility of having other symptoms which you may encounter, but without knowing that they could be related with Parkinson's disease. Thank you very much. I am sorry if I don't have too much time for questions, but I'm more than happy to answer if there are questions. I think that you are mute, Amanda.
Yes. So thank you. That was a wonderful presentation with very interesting information. I have one question that I can, Mary asked, can the feeling of a hair that's on the arm be a very early symptom of Parkinson's disease?
Oh, it's a very interesting question. I would not say that she may develop Parkinson in 20 years from now. This is a sensation. The idea of this lecture is not to be scared and say, oh my goodness, I have restless leg syndrome, I'm going to develop Parkinson's disease. What do I have to do? I have to go to see a physician. What are the tests? There are no tests. There is nothing right now which can tell you if you develop Parkinson's disease. You can have this sensation without having anything to do with abnormalities in the brain, which may be seen in Parkinson's disease. It's a sensation. Just see in the future if you have some other non-motor features, which together may say that in the future you may develop Parkinson's disease, but this is not a sign, and I would not be scared right now, living my life because I have this type of sensation. No way, Mary, please enjoy your life, okay?
And there's some other questions. I'll just read them out so we can tell people that that they will receive we can see if we can send out a link to the recording, but the recording will be posted on our website and on the APDA YouTube. So you will be able to look back at the presentation. And also somebody asked, can we share the slides? I think if Dr. Bortan is okay with that, we can send out the slides to people. And if there's more questions, please feel free to ask. We have one from Christine. Do some Parkinson's patients go through periods when the tremors are good and bad? I'm thinking Christine's asking about kind of fluctuations, I guess, in
Maybe, yes,
motor.
definitely. This is something which we are asking all of our patients. Fluctuations in intensity of the tremor can be seen, and I'm not so sure if she's taking medication or not, but tremor can decrease after taking specific medications which are taken to decrease the tremor. Sometimes the tremor can be worse due to anxiety, due to stress, due to wearing off of medication for Parkinson's disease, due to dehydration, due to other underlying medical conditions. Yes, indeed, you can see fluctuations in tremor.
Kathy asks, are people with familial tremor more apt to get Parkinson's disease?
What type of tremor? I'm sorry.
Familial. So I think a essential tremor or.
Yes, this is a very interesting question, and there are different studies and articles, studies which were done in families, usually retrospective studies. There is a very mild increase in risk of incidence of Parkinson's disease in patients who had essential tremor, but is very, very vague. I mean, maybe less than 5% those patients may develop symptoms of Parkinson's disease in the future, but we do not have a real connection between essential tremor and Parkinson's disease, and it's very hard to define at this time what is the risk of having Parkinson's disease. Well, we know based on different studies that maybe less than 5% of the patients who had essential tremor may develop in the future Parkinson's disease, but we do not know which one of the patient is going to develop that.
Lori asks, can levodopa help with gastrointestinal cramping?
Sometimes gastrointestinal cramping is a wearing off phenomena. And some patients are noticing that the cramping is going away after taking levodopa. Yes, in these patients can be noticed that sometimes it's not helping. Like I said, every patient is different, and we have to try different types of medications and to vary those medications to see what particular medication or management or treatment is working for that patient. Because of this, is very important to discuss with the patient. Sometime we ask the patient to come to discuss other symptoms, because it's one visit of 40 minutes, 30 minutes is totally not enough to discuss about all of these symptoms which we were presented here.
Yeah, Thomas asked, can symptoms come and go? Like,
yes. What symptoms? Depend on what, non-motor symptoms or motor symptoms?
I think he doesn't specify in his question, but I would all symptoms come and go, really, can fluctuate and come and go over time.
Then come and go means fluctuations. That doesn't mean that they are going away totally. They can go away for a couple of hours after taking medications. I'm talking here about motor symptoms. In terms of non-motor symptoms, smell, for example, loss of smell is not coming back, it's lost. Orthostatic hypotension, unfortunately, dysautonomia is describing patients with Parkinson's disease and is not going to be improved. Is improved. The improvement is just improvement of the symptoms, but is not producing a curing of this problem in the body of the patient. Then there are symptoms which are not coming back, but motor symptoms can improve after taking medications, but they can be noticed when the medication is wearing off.
Shireen asks, my husband is in advanced stage PD and has developed dementia. a lot of what you described, like sudden confusion, impaired judgment, cognitive impairment, it is so frustrating. He cannot answer some simple questions and can be in a fog sometimes. Is it possible that this is something else? Could this be something else? Question mark.
Oh, it's such a, I'm sorry, I'm really sorry because you are going through this. Likely because he has long Parkinson disease and is late stage of Parkinsonism. Likely this problem is related with dementia with Parkinson disease. Sometime, if it's a sudden onset of confusion or sudden onset of psychosis, or he may have a sudden hallucinations, delusions, in that specific type of sudden symptoms, we have to think about something else, like, does the patient has a urinary tract infection? Is it a severe metabolic abnormality? Does the patient have significant orthostatic hypotension? Otherwise, something else is very, very hard to think that the patient could have, especially if it's a gradual, progressive worsening of cognition decline over the years after many years of having Parkinson's disease.
Thank you for asking such wonderful questions, courageous questions, really. And thank you, Dr. Bortan, for being here. There's a lot of, there's a vast, vast kind of spectrum, I guess, of non-motor symptoms. And I always learned something new, and these are hard things to, these are hard symptoms to kind of stay up to speed on and understand and make sense of. So I appreciate it. We will share the, we have one more.
Okay.
What about loss of balance? Is this a non-motor symptom? I have no tremor, but a severe loss of balance. What treatment options are out there for this symptom?
Loss of balance, I assume that the patient had, the patient who is asking is having Parkinson's disease. Loss of balance can be seen in Parkinson's disease, because of freezing, because patient have this sensation of losing balance when turning. It's a very general and broad symptom, loss of balance. You can have loss of balance when you have orthostatic hypotension. Usually, if the loss of balance is due to Parkinson's disease, is due to freezing of gait. Freezing means your feet are stuck on the floor. Usually is responding to levodopa medication. Is responding very well to physical therapy, is not resolving the problem, is not going to cure the problem, but physical therapy is something which is amazing, and it can improve significantly loss of balance in patients who had Parkinson's disease. Maybe not all of the patients are benefiting from this from physical therapy, but a combination between medication, appropriate and optimizing medication for Parkinson's disease, and physical therapy can make a difference.
Thank you. Thanks for answering that last question. So we are going to wrap up our webinar for today, and oh no, we have one more question.
It's okay. If I don't mind. My next question is at 2:30.
Okay. All right. What tests determine orthostatic hypotension? I think dehydration has a big, is a big issue. UTI has been ruled out many times.
It's a simple test. In the office, all of our patients who had Parkinson's disease, they have the blood pressure checked sitting, immediate standing, and standing after 3 minutes, or 3 minutes after standing. And if we notice that the blood pressure is dropping more than 20 points, we are concerned about orthostatic lowering blood pressure. then in that situation, we're going to jump on the patient and ask different questions. How much water are you drinking? Majority of the patients are not drinking. The way in which I am doing, let's say, I am asking my patients to take each dose of medications. Usually medication for Parkinson's disease sometimes is taken 3 times a day, sometimes 4 times a day. And I'm asking them, don't forget, every time when you take a pill for Parkinson, take it with 1 cup, 8 ounces of water. Very important. And not sipping. Not sipping, take a sip and leave the glass or cup close to you because you're going to forget. It's not a cup just for entire morning. Take an entire cup of water with the pill in 5 minutes. That is going to help you to remember to drink water with each pill of medication. And of course, you have to drink in between the pills. I like my patients, if they don't have any type of restriction, water restrictions from their physicians, from their cardiologist or nephrologist, I ask them to try to measure drinking in between 48 and 64 ounces of fluids a day. And always I'm saying fluids means no beer or wine. Means water. Some people do not like water. They want different types of, soda. I'm not okay with soda, but if they don't like water, they can do a mix between water and some type of soda or Gatorade. It's okay, but they have to drink. This is the idea. There are many other causes of orthostatic hypotension. I don't think that we have time to discuss, but always discuss with your doctor when you go and visit the doctor. Please check my blood pressure if it's possible, sitting and standing after 3 minutes. It's very important.
All right. So thank you so much for joining us, everyone, on this warm July summer day. Everyone should have a glass of water. And we will see you next time.
Okay, thank you so much. Thank you everyone for having, to participate. I know that it's Friday afternoon and perhaps you want to take a nap. I would advise you to have like 30 minutes nap if it's possible. When you wake up, drink water. And if you have more questions, you can send by email to Amanda and I can answer if I can, obviously. Thank you so much, Amanda, for having me.
Thank you. Bye-bye.